Good morning. So essentially we heard a lot of this before, but you really, when we talk about risk stratification and you talk to a patient, a 27-year-old is completely different than a 17-year-old. They're more reliable, they're willing to wait longer, and depending on their degree of ligamentous laxity, that'll make a big difference as far as, let's see if this can advance, as far as what you're going to tell them as far as cartilage damage in the future. And unlike, I think, what was said earlier, I've seen plenty of people have significant cartilage injury on their third dislocation or their fifth dislocation. So Kevin asked me 5 tips in 5 minutes. Tip number 1, MPFL only works. You don't always have to do an osteotomy. It's very important to release laterally if tight, and I think the message is always don't do any more lateral releases, stop doing lateral releases. We're talking about lateral release in isolation, not lateral release if they're stuck with a tight lateral retinaculum. For the femoral tunnel, all I care about is isometry, and a lot of these studies are misleading because all the cadaveric studies are done on normal knees. These are not normal knees. The patellar fixation. Don't break the patella. You want to have a miserable patient, you're going to have a miserable patient with a patella fracture. And then lastly, you have to look at the patient's strength and stability, and that's where physical therapy comes in. So there are several studies now showing that alta and dysplasia don't matter. Two that were published just this year. One was 52 patients with no correlation found between the collected risk factors and their postoperative outcome scores. Mind you, postoperative outcome scores for patella don't take into consideration instability. I can tell you if I had an operation and my patella continued to dislocate, I wouldn't be particularly happy even if my outcome scores were excellent. Secondly, 72 patients without cartilage defects, they had low redislocation instability rate regardless of bone pathology, including elevated TTTG, Catam de Champ. Number 2, here you can see me examining a patient. When I centered the patella in the trochlear groove, I want to be able to flatten their patella. I want to be able to lift up that lateral facet. Otherwise, they are going to have a lateral lengthening. So my point is release laterally if you must, but don't release laterally if, when you check for eversion, you can get them to neutral. For the femoral tunnel, start at the palpable sulcus, then check isometry, then check fluoro, because fluoro doesn't matter if they're not isometric, so I do that last. We've seen this diagram a couple times today, but again, these studies are very misleading because many patients are not isometric because of their patella alta if you put it straight at Shuttle's point, so look at isometry first. MPFL location, if its Catam de Champ is above 1.4, their TTTG is above 20, it may not be at the same point. So look at where it's isometric. Potentially with a patient with patella alta, you have to go higher on the femur. The image Jason just showed was extremely high, but you may have to go a little bit higher than usual. So what happens if you put the tunnel 2 anterior? Here you can see they were high and they were anterior, and look at that damage on the patella. That's a disaster. Secondly, here you can see another high femoral tunnel, and you can see severe cartilage and bone loss in the patella from a non-isometric graft. If they just get stiff, you're lucky. Most patients will get more than stiff. They'll have significant patella damage. Here, another non-isometric graft placed anterior and significantly proximal. Again, you can see significant tunnel widening in the patella. This is risking a patella fracture. What about here you can see, again, anterior. This can cause overload and patellar chondrosis. Number 4, for patellar fixation, don't violate the cortex or the cartilage. You can see that anchor in the patella. It comes right across into the lateral facet of the patella. This girl not only got stiff, but she developed significant pain. You take an unstable patient, you add stiffness and pain, they're absolutely miserable. Here again, you can see patella tunnel in the wrong place. I do tend to open up the capsule, unlike Jason's video, because I think that helps palpate the articular surface and it avoids placing the tunnel too proximally, as they did in this case with significant bone loss. And beware of large anchors. I use the smallest anchors I can. I use all suture anchors that are cortically based. Here you can see what happened with some large anchors, potentially placed a little too close to the dorsal aspect of the patella. My pearls, just small anchors. Consider a quad turn down if it's a very, very small patella. Center it in the trochlea when securing the MPFL. Make sure you're not medially subluxing them. And number 5, don't let them go back until good hip and quad control. Here you can see a patient doing a single hip step down. You need to make sure they're stable before you let them go back to sports. Thank you.